So this is the in-class activity for Chapter 13, the spinal cord, spinal nerves, and spinal reflexes. So Part 1, a closer look at a CNS injury. So we're going to look at how injuries would look different if they are in the brain versus the spinal cord. So Part 1, brain versus spinal cord CNS injury. Dr. Green and Dr. Carter, nearing the end of the first year of their residency, were working in the emergency department of County General Hospital when a call came in over the radio. Paramedics were bringing in a young man with injury sustained in a diving accident. A minute later, the doors to the department burst open and the paramedics wheeled in a young man. The senior paramedic reported that the patient was swimming at the local quarry and did a forward flip into the water, striking some submerged rocks. He was in a hyperflex tucked position when he hit the rocks, lacerating the right side of his head and neck and upper back. The patient indicated he had severe pain upon impact and a loss of sensation and movement in his arm and leg. He may have lost consciousness, but he's not sure. He also complains of a severe headache, dizziness, and nausea. And just if you're wondering, this is what it means to be in a hyperflex tucked position. Dr. Green and Dr. Carter disagreed on the possible diagnosis. Dr. Carter said, after seeing the head wound and the amount of blood loss and given the symptoms, I want to confirm my suspicion that this patient has a brain injury. Dr. Green disagreed. I think that the other signs and symptoms indicate a spinal cord injury, and that's what we should investigate. The following table summarizes the findings of the evaluation, which included a physical exam, x-rays, an MRI, and neurological tests. So sensory testing showed a decreased sensation to crude touch, pain, and temperature in the left upper and lower extremities. Decreased sensation to fine touch, pressure, and vibration in the right upper and lower extremities. Motor testing showed decreased strength and movement of the right and upper and lower extremities, decreased strength and movement of the left abdominal muscles, abnormal response of the patellar reflex in the right lower extremity, and a positive Babinski sign on the right foot. The general examination revealed abnormal pupil response of the right eye. The other vital signs were in normal limits. Cognitive testing is normal. And the X-ray and MRI showed no fractures present in the skull, fracture in the 7th cervical vertebra, significant swelling in the spinal canal in the C7 to T2 region, and the spinal cord appears to be intact. So Part 1, number 1. Based upon what you have learned so far, do you think that this is a spinal cord problem or a brain problem? What is the name of the areas of the spinal cord where axons cross sides? Now you may have said spinal problem just because this is the spinal cord chapter, but you are right, it is a spinal cord problem. But since he hit the right side of his head, neck, and upper back, but his symptoms involved both the left and right sides of the body, especially when it came to sensory and motor problems, that is what indicates that this is actually a spinal cord problem. So to answer the second part of the question, what is the name of the areas of the spinal cord where axons cross sides? Myelinated axons cross sides at the white commissures, and unmyelinated axons cross sides at the gray commissures. So we bring this up because, as we've mentioned before, the left side of the brain controls the right side of the body, and it also receives sensory signals from the right side of the body. And the right side of the brain controls and receives sensory signals from the left side of the body. However, when we look at the spinal cord, axons of both sensory and motor neurons cross over at different points along the spinal cord, and we're going to go into that in more detail at the beginning of AMP2. But here's kind of what it looks like. So imagine this is your spinal cord, and you have sensory information about pressure and sensory information about temperature on one side of the body, and you also have sensory information about pressure and temperature on the other side of the body. So the two different colors represent the two different sides of the body. So notice that some axons cross over lower than others. So like in this example, the information for pressure is crossing over right here. So it's going from the right to the left side lower than the information for temperature. So the information for temperature doesn't cross over until it gets up here. Now by the time it gets in the brain, the left side of the brain has all of the information for the right side of the body, and the right side of the brain has all of the information for the left side of the body. But depending on where an injury to the spinal cord occurs, you could be affecting both sides. So a spinal cord injury has the ability to affect sensory and motor pathways on both sides of the body. So for example, if I had an injury here in this portion of the spinal cord, I would affect pressure information from this orange side. So notice it's the orange neuron. So pressure information from the orange side, but then I would be affecting temperature information from the green side. Right? So if I have an injury at different points in the spinal cord, above or below, where different axons cross over from one side to the other, it can actually affect both sides of the body. Part 1, Question 2, Critical Thinking. How would the results have looked if it had been a brain injury instead of a spinal injury? Well, the biggest take home and the biggest difference would be that if it were a brain injury, all of the signs and symptoms from both of the sensory and the motor testing, so those first two rows of the table, would have affected only the left side of the body, in this case, in which it would have been a right brain injury. So that is a very key difference. With a spinal cord injury, you can get sensory and motor deficits from both the left and right sides, whereas with a brain injury to just one side, you would have all of your effects would be on the opposite side of the body. Some other possible differences. So the abnormal pupil response that he had on only one side is actually due to damaged sympathetic pathways in the spinal cord. So a brain injury would likely not have caused the same reaction unless he had damage to the brainstem optic nerve or oculomotor nerve. Cognitive testing could have potentially been abnormal in the instance of a brain injury because cognition involves processes that take place in the cerebrum, and the type of cognitive testing deficits would depend on the specific area of the brain affected. There would also be the possibility for a skull fracture and or swelling in the region of the brain affected. And there could have been a possible epidural hemorrhage if he had had a skull fracture, or a subdural hemorrhage that would have shown up on the MRI and X-rays. Part 1, Question 3. Describe the overall anatomy of the spinal cord. How many spinal segments are there? What do the terms conus medullaris, filum terminale, and cauda equina mean? Where does the spinal cord end? Which structures prevent spinal cord movement within the vertebral canal? So actually, to answer the third question first, in adults, the spinal cord ends between L1 and L2, so it is approximately 18 inches long. There are 31 spinal segments, 8 cervical segments, 12 thoracic segments, 5 lumbar segments, 5 sacral segments, and 1 coccygeal segment. The conus medullaris is the tapered conical end of the spinal cord. The filum terminale is a strand of fibrous tissue that extends from the conus medullaris to become part of the coccygeal ligament. The cauda equina are the long dorsal and ventral roots of spinal segments L2 to S5, and technically also coccygeal 1. Structures that prevent excessive spinal cord movement include the superior and inferior or up and down movements are prevented by the connections of the meninges at the foramen magnum of the occipital bone that prevents superior movement, and inferior movement is the coccygeal ligament at the bottom. Lateral side-to-side movements are prevented by the denticulate ligaments, which are extensions of the pia mater. Number 4, label the cross-sectional view of the spinal cord. So I'm going to stop there and we're going to do the labeling first, then we'll answer the rest of the questions. So looking at this image, number 1 would be the anterior horn of the gray matter. Number 2 would be the posterior horn of the gray matter. Number 3 would be the gray commissure. So again, the gray commissure is where unmyelinated axons are crossing sides. We can also further narrow this down into the posterior gray commissure that goes above the central canal and the anterior gray commissure that goes below the central canal. Number 4 would be the anterior white column. Number 5 would be the lateral white column. Number 6 would be the posterior white column. Number 7, they highlighted in green so that you could see the area it was talking about better, but it is the anterior white commissure, which is where myelinated axons cross sides. We don't have a posterior white commissure because the two posterior white columns butt up right against each other. Clearing the board to make more room. Number 8 would be the anterior median fissure. Number 9 would be the posterior median sulcus. Even though they put the number right down here, it technically is just this little small groove at the very top. Number 10 would be the central canal. Number 11 would be the ventral root, also called the anterior root. Remember, know that the ventral root will be on the same side as the anterior median fissure. Number 12 would be the dorsal root, also called the posterior root. Number 13 would be the dorsal root ganglion, also called the spinal ganglion. And number 14 would be the spinal nerve. The second part of the question says, how does the relative percentages of white matter and gray matter change as you move down the spinal cord? Differentiate between motor information and sensory information. So in the cervical and lumbar regions, there are enlargements of the gray matter called the cervical enlargement and the lumbar enlargement. These enlargements are due to the abundance of neuron cell bodies that are necessary to process the sensory and motor information for the upper and lower limbs. So in the cervical region, you have the nuclei responsible for all of the neurons going out to your arms, and in the lumbar region, you have all of the nuclei or all of the cell bodies responsible for the neurons going out to your legs. So in general, sensory information is processed and carried on the dorsal or posterior side of the spinal cord. The dorsal root carries only sensory axons. The dorsal root ganglion contains sensory neuron cell bodies. And sensory nuclei in the gray matter are primarily in the posterior horns. And also you can remember that sensory information is information going from the periphery up to the brain, so it is ascending information. Motor information in general is processed and carried on the ventral or anterior side of the spinal cord. The ventral root carries only motor axons, and motor nuclei in the gray matter are primarily in the anterior horns. And motor information is going from the brain out to the peripheral effectors, so it is descending information. Part 1, question 5. The patient had a hemisection of the spinal cord at C7. Look at the map of dermatomes. Where would the patient have numbness of the skin, and where would the patient still be able to feel? So to let you know what a hemisection looks like, that is when half of the spinal cord is damaged. So the area of cord damage would be shown here by the salmon color. So since the hemisection occurred at C7, the loss of feeling would occur in spinal segments below the injury. So those neurons are unable to rise up farther past C7. So you would have deficits anywhere on this picture where you see C8 to S5. So the patient should have normal sensation in most of their arms, in their shoulders, in their neck, in their head, and in their face. And the patient should have loss of sensation underneath the arms, so where you see C8 and the T1 and 2, Also, the torso, anywhere you see a T or an orange color, anywhere you see the L or green color, and anywhere you see the pink S color. So the complete torso and lower limbs would show a loss of sensation. And then because of the nature of the hemisection of a spinal injury, and we talked about the way axons crossed, that means that loss of pain and temperature and touch would be on this patient's left side, which is the contralateral side to the injury. So if the right side was injured, you'd have loss of pain, temperature, and touch on the contralateral side. So again, anywhere you see on this picture from C8 to S5, he would have loss of pain, temperature, and touch. And then loss of fine touch, pressure, and vibration on the right side or the ipsilateral side. Again, this would be C8 to S5 regions of the body. Number 6, describe the layers of connective tissue surrounding a spinal nerve. Why are spinal nerves called mixed nerves? So spinal nerves have 3 layers of connective tissue. The epineurium surrounds the entire spinal nerve. The perineurium separates the spinal nerve into bundles of axons called fascicles. And the endoneurium surrounds each individual axon. A spinal nerve is called a mixed nerve because it carries both sensory and motor information. The spinal nerve is formed when the ventral root carrying motor information and the dorsal root carrying sensory information come together to form a single nerve. Number 7, why did the patient have a positive Babinski sign on his right foot? Is this normal or abnormal? So a positive Babinski sign means that his toes fanned out when the lateral sole of his foot was scraped. A positive Babinski sign in adults is abnormal. It is normally only seen in infants up to 12 and 24 months of age. So basically there's a reflex in the spinal cord called an extensor reflex that causes the toes to fan out. After you've reached the age of 12 to 24 months, the motor neurons in the spinal cord have finished developing and they are fully myelinated. Then the brain is able to exert control over this reflex, and so the brain inhibits that normal spinal extensor reflex and turns it into a flexor reflex in which your toes curl. So a positive Babinski sign in an adult suggests damage to the spinal cord. The brain is no longer able to inhibit the original spinal reflex because of damage to the motor neuron pathway. So in this patient, he had a positive Babinski sign on his right foot because of the damage to those motor neurons that were traveling down his spinal cord due to his spinal injury. So his brain was no longer able to exert control over that reflex in the foot, and so it went back to being the extensor reflex that you're born with as an infant. So this is part 2. It takes a lot of nerve. Amanda had been on the go the entire day. Her busy schedule had included a job interview, a class presentation, and an unmerciful physics exam she would rather not discuss. Once home, she was determined to head straight for bed, but there was one minor complication. She hadn't managed to eat anything in the midst of all of the day's activities. While scrambling to put together a fast and easy meal at home, she inadvertently touched one of the hot burners on the stove. Fortunately, she reacted by jerking her hand back before any damage was done. The week continued to be busy for Amanda. She had taken 3 exams, and as if that wasn't stressful enough, her sister was ill, and Amanda had to spend much of her time helping out at home. By the end of the week, Amanda decided to go to the beach for a walk and some genuine relaxation. The day was warm, and Amanda took off her shoes so she could walk barefoot and feel the sand between her toes. Halfway down the beach, she stepped on something extremely sharp and withdrew her foot in pain. As Amanda hopped around the sand on one foot, rubbing the other to ease the pain, she decided she put her shoes back on. Part 2, question 1. Amanda's response when she touched the hot stove was an example of a flexor withdrawal response. Describe this reflex. then show which parts of the reflex make up the reflex arc. So here's my free-handed drawing of a cross-section of the spinal cord, and so we're going to use this to draw out the reflex as we talk about it. So the first step is that the painful stimulus is transmitted along a sensory neuron to the dorsal side of the spinal cord. So I have my pain stimulus stimulating the dendrites of a sensory neuron. Here's my sensory neuron cell body, which would be located in the dorsal root ganglion. And then here is the axon coming in through the dorsal root to the dorsal side of the spinal cord. And I know this is the dorsal side because this down here is my anterior median fissure. So that is step one. The sensory neuron is stimulated and takes the information to the spinal cord. The sensory neuron is going to synapse onto an excitatory interneuron in the spinal cord. All right, so I've drawn out a green excitatory interneuron, which is located within the spinal cord itself. The excitatory interneuron stimulates a motor neuron, which sends a signal to contract a flexor, which allows you to pull the hand away from the painful stimulus. So this purple neuron is going to be my excited motor neuron. So it's excited because it's being sent a signal by an excitatory interneuron. So this would probably be glutamate that's released at the synapse. So my excited motor neuron is now going to send an action potential out to the flexor. You'll get acetylcholine release at the neuromuscular junction, and then you'll get muscle contraction in the flexor. The excitatory interneuron is also going to stimulate an inhibitory interneuron. So again, my green excitatory interneuron is going to send a signal to a motor neuron, but then it's also going to have an axon collateral or a branch of the axon where it's also going to be talking to an inhibitory interneuron. So the excitatory interneuron is basically turning the inhibitory interneuron on. That's why I use the colors green and red. Now the inhibitory interneuron is going to inhibit, because that's what it does, it's going to inhibit the motor neuron that controls the extensor. All right, so here this is going to be my inhibited motor neuron. So again, notice my motor neuron cell bodies are on the ventral side of the spinal cord going out through the ventral root. And in this case, this motor neuron is going to be inhibited so that no signal for the extensor to contract can be sent. And that's because I don't want two muscles that are doing antagonistic actions. I don't want them to contract at the same time. And this is also called reciprocal inhibition. And then finally, both interneurons are also going to send the information up to the brain so that Amanda will be consciously aware of what happened. And this is also how she will feel the pain. So both my green excitatory interneuron and my red inhibitory interneuron are going to have separate branches that are going to go up toward the brain all the way up through the spinal cord. So that is the flexor reflex, also known as the withdrawal reflex or withdrawal response. And now we'll look at what components of this reflex make up the reflex arc. And it's called an arc because if you were to draw a big giant arrow from where things start to where they end, it looks like a giant arc or arch. So we're going to, the reflex arc, and then again, this is very general. This is to be applied to multiple types of reflexes and not just the withdrawal reflex. So step one is the arrival of a stimulus and the activation of a receptor. Step two is the activation of a sensory neuron. Step three is information processing in the brain or spinal cord. Step four is activation of the motor neuron. And then step five is response by the effector in the periphery. And again, this is generalized to all reflexes, so that's why we kept the descriptions vague. But still, this is an arc. You start in the periphery, you go to the central nervous system, and then you go back to the periphery. Part 2, Question 2. Amanda's response when she stepped on a sharp object is an example of the flexor withdrawal response in conjunction with the crossed extensor reflex. Describe how this more complicated reflex works. So the same steps that we just described on the previous slide for the flexor reflex also apply here. So I'm not going to rewrite out all of those steps, but I will show them to you visually. So this will be a review of the flexor reflex, also known as the withdrawal reflex. So let's do a quick review. Remember, we have sensory information that comes through on a sensory neuron to the dorsal side of the spinal cord. The sensory neuron is then going to activate an excitatory interneuron in the spinal cord. The excitatory interneuron is going to excite a motor neuron that controls a flexor. This is going to cause the flexor to contract, and so you pull your arm or leg away from the painful stimulus. At the same time, the excitatory interneuron is also activating an inhibitory interneuron. And the inhibitory interneuron is inhibiting a different motor neuron that controls an extensor, and it's going to prevent the extensor from contracting so that your opposing antagonistic muscle groups do not contract at the same time. And then finally, both interneurons send their signals up to the brain for conscious processing. All right, so all of that was the same as we previously looked at. So that's part of the flexor withdrawal response. So now we're going to add in the crossed extensor reflex. So to add in the second part, we need to also remember that you have flexors and extensors on both sides of your body. So in your right leg as well as your left leg, and your right arm as well as your left arm. So I do have a flexor and extensor on the opposite side of the body. And with the crossed extensor reflex, I want to do the opposite on the other side of the body than I did on the side that had the painful stimulus. So on the side with the painful stimulus, I want to activate a flexor so that I jerk my leg away from the painful stimulus. But on the opposite side of the body, I want to activate the extensor so my other leg stays straight and I don't fall over. And because I'm activating the extensor, I want to inhibit the flexor because, again, I don't want opposing muscle groups to contract at the same time. All right, so knowing that I need to activate an extensor on the other side and I need to inhibit the flexor on the other side, I can look at what I've already got here. I don't need any more interneurons because I've already got interneurons. I've already got an excitatory interneuron in green, and I've already got an inhibitory interneuron in red. So how would I hook these final components together? So the excitatory interneuron is going to stimulate the motor neuron on the contralateral or opposite side that controls the extensor. Because remember, on the other side, I want my extensor to contract, so I want to excite it. Exciting it means it's going to contract. I already have an excitatory interneuron, so I just need a branch from that neuron to cross over and tell this extensor, hey, contract. So there it is. Another branch of my excitatory interneuron comes over here and tells this guy to contract. Likewise, I already have an inhibitory interneuron, so I can use it to inhibit the motor neuron on the contralateral side that controls the flexor, and this is another example of reciprocal inhibition. So again, on the other side, I want to inhibit the flexor. I already have an inhibitory interneuron, so I just need another branch from that neuron to come over here and inhibit the flexor. So notice I'm exciting the flexor and inhibiting the extensor on the side with the painful stimulus, and I'm inhibiting the flexor and exciting the extensor on the opposite side, and that is the crossed extensor reflex. Last question. What are the 4 ways that reflexes can be categorized? Give an example of each type. So the first way to categorize reflexes is by development. Reflexes can be innate, which means you are born with them. They are genetically determined. And an example of this is the withdrawal reflex. This is opposed to acquired reflexes, which are reflexes you learn over time and with practice. An example of this is like staying balanced on your bike or slamming on the brakes of your car, or many things you do if you play sports or learn to play a musical instrument or paint or any other hobby or general activity that you repetitively partake in. You can also group reflexes by the type of response. So somatic reflexes are reflexes where the effectors, or the things in the periphery doing the job, are skeletal muscles. And an example is a withdrawal reflex where we were stimulating flexors and inhibiting extensors. And this is contrasted with visceral or autonomic reflexes, in which the reflex effectors are smooth muscle, cardiac muscle, and or glands. For example, when your heart rate speeds up when you get scared, that is an example of a visceral reflex. You can also categorize reflexes by the complexity of the circuit. A monosynaptic reflex is the fastest because it only involves a single synapse. And an example of this is the stretch reflex. And then you can also have polysynaptic reflexes, which are reflexes involving 2 to hundreds of synapses. And an example of this would be the withdrawal reflex. And finally, you can categorize reflexes by processing site. Spinal reflexes, the inner neurons that do the processing, are located in the spinal cord. An example of this is the withdrawal reflex. Versus cranial reflexes, where the inner neurons that do the processing are located in the brain or brainstem. An example of this one is a sneezing reflex, where the processing center is in the medulla oblongata. So notice that one reflex, like the withdrawal reflex, can be categorized in multiple ways. And usually on an exam or quiz, we might ask you the different ways that you can categorize a withdrawal reflex. So you can notice from this little chart here that I can categorize the withdrawal reflex in one of each of these different categories. So make sure you understand how that works. And that is the end of the Chapter 13 activity.